Thank you so much for joining the NAMI Maryland's 39th Annual Conference. My name is Cherie Strong, and I am the Board of Directors, NAMI Maryland. I'm on the Board of Directors for NAMI Maryland, and also a volunteer leader with NAMI Southern Maryland. I will be your moderator for today's session. This workshop session is Advocacy for Mental Health Professional-Led Mobile Crisis Teams in Montgomery County, Maryland, presented by Marilyn Kresky-Wolff and Naomi from the Silver Spring Justice Coalition. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website. This workshop will describe ongoing advocacy for adopting the CAHOOTS model of mobile crisis from Eugene, Oregon, which is a mental health professional and a peer support-led model adopted for funding states in the United States Senate. Our efforts are centered on removing police as first responders for mental health crises and expanding teams to 24/7 coverage. If this is not the workshop you are meant to attend and would like to join another, please click the black button on your browser or click the conference drop-down on the left-hand side of your screen and select sessions from the menu to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them to the social wall on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenters after their presentation has concluded. If you have any questions, comments, or technical issues, please post them to our social wall, and our technical assistant will address them accordingly. When posting on the social wall, please be aware that it is a 20-second delay between the presentation and the stream on Conference Tracker. When the workshop session closes, you will be prompted to fill out a brief survey. If you would like to receive CEUs for this workshop, you must complete the survey in order to qualify. I'd like to now welcome our presenters for today's workshop, Marilyn Kresky-Wolff and Naomi Nim. Thank you so much for joining us today.
Okay. Good morning. I'm Marilyn Kresky-Wolff. I'm a retired social worker with a master's in public health. I retired 2.5 years ago from being the executive director of Open Arms Housing, a housing program for homeless women in DC. I'm also a former NAMI Baltimore executive director, but that was a very long time ago. What I'd like to do for my piece this morning is describe the national local context for alternatives to police response and do a critique of the crisis intervention training that police have historically gotten in this country. What we want to do is set the stage for why change is critically needed in crisis response in Maryland. So national concerns and outcry across the country about deaths and harm caused to people during encounters with police. There's been a significant rise in publicity. I'd say it's almost daily in various media, mainstream media and political arena, around calls for change in policing and behavioral crisis response. Approximately 1,000 people in the United States were fatally shot by police officers during 2018, and people with mental illness were involved in approximately 25% of those fatalities. There have been numerous reports of police feeling overloaded and not feeling equipped to deal with people with mental illness. The prevalence of police involvement with people with mental illness. As you all know, mental illness is the most prevalent disability in the United States. Accounts for 1 in 10 of all law enforcement responses. Jails play a primary role in housing people with mental illness and/or substance abuse disorders. A mobile crisis-oriented response can de-escalate situations, assess, and begin to address health needs. The role of race in police involvement. Data show that in Maryland, Black residents experience higher rates of arrests and receive more than 45% of criminal citations. Victims of violence by police were majority white, but disproportionately Black, with a fatality rate 2.8 times higher among Blacks and whites. And there's also a cost element. Cost savings if police are removed as first responders. According to a 2019 Treatment Advocacy Center report, more than $17 million was spent in 2017 by reporting law enforcement agency transporting people with severe mental illness. It's extrapolated to law enforcement agencies nationwide. This number is a mind-boggling $918 million, or 10% of law enforcement's entire annual operating budget. Next slide, please. Trends in alternative to police models have been developing across the country. There are actually four major types: a mental health-led model, a community or peer or citizen-led model, a police-led model, and co-responder model where mental health and police respond together. About 2 years ago, the Substance Abuse and Mental Health Services Administration introduced what their recommended national model is, which they call Crisis Now. Crisis Now is a co-responder model, which involves both mental health and police, but does emphasize the role of mental health. The components are, and this is what SAMHSA is proposing as an ideal model for the entire country, that there be a regional crisis call center that is 24/7 clinically staffed with telephone and text and chat capabilities, that there is an air traffic control center component, meaning that there's quality coordination of crisis care, including the dispatch, those who receive the first call, and mobile crisis team response, which means that there should be a response of this kind available to reach any person in the service area in his or her home in a timely manner. The Crisis Now says use police only when absolutely necessary. And there's a letter by a number of advocacy and professional groups, including NAMI, which states that this does not go far enough. Next slide, please. I just wanted to read from the letter that the advocates sent to SAMHSA. Increasing the capacity of social workers and other mental health professionals to work alongside law enforcement to co-respond to address situation does not go far enough in reducing the role of law enforcement. Now I'd like to describe briefly the various models of crisis response. The CAHOOTS model, which has been pioneered in Oregon and in now many cities across the country. Baltimore crisis response are considered mental health or mental health trained and peer-led models. The community responder model relies only on peers and volunteers and dispatch for two broad categories of calls for service that do not require police presence, such as calls related to homeless people, behavioral crises, substance use wellness checks, disorderly conduct, trespassing, noise complaints. These models are demonstrated by Mental Health First. This model is demonstrated by Mental Health First, serving Oakland and Sacramento, California, which is a non-police model using a medic and trained volunteers who work with people who historically do not call 911. Slide 4, please. Police-involved models include models where the police receive the first call and the dispatch. Example is our own Montgomery County and many others around the country. In Montgomery County, the crisis team is called by the police, can be called by the police only, unless a citizen calls the crisis center. him or herself. Next slide, please. Wanted to discuss the developments in funding which can assist us in moving to these mental health-led models. The U.S. CARE Act, which is part of COVID response, allows use of funds for mobile crisis teams on the model of CAHOOTS, which Naomi will describe soon, and congressional legislation, including the permanent expansion of mental health care services via telehealth in the American Rescue Plan. It allows the CAHOOTS-style program for health professionals to act as first responders when there is a 911 call related to someone experiencing a mental health crisis. On October 1st of this year, legislation passed in the Maryland legislature, Crisis Behavioral Health Crisis Response Services, was sponsored and successfully passed by Delegate Laura Charkodian and Senator Malcolm Augustine. This authorizes the Maryland Department of Health to prioritize awarding grants under the Behavioral Health Crisis Response Grant Program to local behavioral health authorities. And there's a lot of money that is tied up in this legislation. First of all, there have been SAMHSA grants to some of the jurisdictions in Montgomery County, but it requires that $3 million was set aside in fiscal 2020, $4 million in 2021, and ongoing in the next year, $5 million, and upping the amount of money invested over the years through 2025. In July 2022, 988 will become the national 3-digit dialing code for the National Suicide Prevention Hotline, Lifeline. As the plenary speakers described yesterday, how this exactly is going to be implemented is not clear. There could be some grants for states to implement this. There could rely on a state tax of 911 calls, but this system is what the SAMHSA and the country will be trying to place this so that there'll be a universal line, which is currently the suicide prevention line, but will expand to be the line to call for mental health crisis across the country. Next slide, please. The other topic that I'm talking about is a critique of the crisis intervention training that police use in many, many jurisdictions across the country. Our observation in Montgomery County and elsewhere, and reports in the media, demonstrate to us that we do not believe that CIT is working, demonstrated by the continuing killing of people in crisis by police. The crisis intervention training course, which is endorsed by NAMI and other groups, is widely implemented and requires an extensive 40-hour curriculum for police taught over 5 consecutive days. It emphasizes understanding of mental illness, incorporates the development of communication skills. It aims to reduce the risk of serious injury or death during an emergency interaction between police and people with mental illness. Research has shown that there are beneficial officer-level outcomes, such as their own experience of satisfaction and self-perception. And there can be there's some evidence that diversion from jail to psychiatric facility does happen, but a measurable decline is found in these outcomes over follow-up time. There is little evidence in the peer-reviewed literature that shows CIT's benefits on measures of arrests, officer injury, citizen injury, or use of force, which of course are the outcomes that we're looking for. Next slide, please. Other factors contributing to the lack of demonstration of CIT benefits are that training and special coding needs to be also delivered, not just to police officers, but to dispatchers. Dispatchers are the key to recognizing community reports with a high probability of involvement of a person with mental illness, and to route CIT officers or other mental health responders there. This is significant because research indicates that the characteristics of the call and this dispatch itself are strong determinants of the probable use of force. Secondly, the fragmented and overlapping US law enforcement system presents challenges in terms of oversight and monitoring, and this extends to gathering statistics. Most US police officers work within small local departments with limited resources, and only 45% of 174 reporting police departments report any specialized response to people with mental illness. And of those, a distinct minority, about 3%, report using the CIT model. And I'll now turn over the presentation to Naomi. Thank you all.
Good morning, and if we could just hold that slide for till I'm ready for it. Thank you so much. So please stop sharing it. My name is Naomi Nim. I am a psychotherapist and dance movement therapist from Silver Spring. My work is psychodynamic and relational, and I treat adults who represent much of the diversity of the region. Before becoming a therapist, I founded a nonprofit that promotes the social and emotional development and empowerment of girls from immigrant, refugee, and impoverished families. My background is also in education and community and political organizing. I co-chair with Marilyn the Mental Health Committee of the Silver Spring Justice Coalition. On a personal note, multiple members of my extended and immediate family have experienced mental illness. This morning, I want to talk to you about the advocacy we engage in on behalf of people experiencing a mental health crisis in Montgomery County. The situation is urgent. The inception of our work in the Silver Spring Justice Coalition, or SSJC, stemmed from the murder by county police of a Black man with chronic mental illness. I'd like to talk to you about an inspiring program from Eugene, Oregon called CAHOOTS that we have been promoting and that we hope will inform changes in Montgomery County mobile mental health crisis response. We know there are lots of concerns about mobile crisis intervention and rising interest in these reforms. So we will give time for your questions at the end. In the spring of 2018, Robert White, a Black man in his 40s, was taking his daily walk near Sligo Creek Park in Silver Spring. A police officer who had been called to this neighborhood on a domestic issue at the home of one of his neighbors saw Robert walking and decided he looked suspicious. Mr. White was well known to his neighbors. They urged the police officer to leave him alone, as Mr. White became more agitated and refused to engage with the police officer. Mr. White had a persistent mental illness that was well managed. The police officer called into his precinct that he thought this was a case of, quote, suicide by cop, unquote, and proceeded to shoot Robert White multiple times. Robert White's death was tragic, senseless, and outraged, and a wake-up call to people in this community. Silver Spring Justice Coalition formed shortly thereafter to address police violence, which is perpetrated disproportionately against Black men. Our coalition of several organizations and hundreds of individuals is comprised of a diverse group of county residents. Please share the first slide. The coalition draws from throughout Montgomery County, including neighbors of Robert White, community members, faith groups, and civil and human rights organizations. SSJC envisions a county where harm by police is eliminated, while community and individuals are empowered. And we aim to reduce the presence of police in our communities, eliminate violence and harm by police, establish transparency and accountability, and redirect public funds towards community needs. As a broad-based coalition, SSJC is focused on changing policing in Montgomery County. We also work in alliance with other groups to reform county, state, and national laws and policies that affect local policing. Finally, we provide a platform to educate, advocate, and organize residents in order to achieve our vision. Thank you. Please stop sharing. The tragedy of Robert White's murder has been repeated 3 times in Montgomery County since 2018, when police have encountered mostly Black men who are mentally ill or in a mental health crisis. In addition, 3 other Black men have been killed by police during this time. Sadly, the ranks of SSJC have grown with the mothers and families of victims and their neighbors and friends. We offer emotional support for the grieving and support to find justice for their loved ones. We remember the people who were experiencing a mental health crisis or mental illness who were shot to death by police in Montgomery County since Robert White was killed in 2018. They are Ryan LaRue, Kevin Koslow, and Fanan Berhe. In July of this year, Ryan LaRue, a Black man aged 21, was shot 24 times, while he sat in his car inebriated, sleepy, depressed, and subjected to multiple commands by police who had full view of his hands and an empty bottle and his handgun on the seat next to him. No crisis unit was called, and the police didn't wait for a quote unquote negotiator who was reported to be on their way. Another family is devastated, and another tragedy could have been averted. In Montgomery County and around the country, there is a growing outcry against police violence and a movement to remove police from mental health response. Mental illness is not a crime and should not be criminalized. In 2019, SSJC began advocacy at the county level to fully fund mobile crisis teams throughout the county. We knew that not until the county could assure all residents, especially all Black and Brown and immigrant residents, that they will be safe from harm in a mental health crisis, would the county have fulfilled its obligation to public safety. Nor would many members of our community trust that they could call for help even in dire circumstances. We know that lives are saved when police are relieved of mental health crisis duties and when mental health professionals and peers respond. SSJC has been working at the county and state level in support of legislation to regulate police use of force, to increase police accountability and transparency, and to reform a county system of crisis response that has relied almost entirely on police for 20 years. This year, as Marilyn said, D20 Delegate Laura Charkoudian and her colleagues in Annapolis passed her bill that provides funds for mobile mental health crisis programs in Maryland that will be staffed by mental health professionals. We work closely with Delegate Charkoudian to build support for this legislation that sets best practice standards for mobile response statewide. We will continue to support her efforts on behalf of Maryland residents to receive the best and safest standard of care when they are experiencing a mental health crisis. Up until 2 months ago, in our county of over 1 million residents, we had 1 mobile mental health crisis unit located in Rockville. Chances were very high that if you or a family member or friend were in distress and you called 911, the police would respond. We now have, since August, 3 mobile crisis teams and funding in place to fund another 4 or 5 units 24/7 within the coming fiscal year. This is a big step in the right direction, but far from sufficient. Police will be answering the majority of mental health crisis calls well into 2022. Please show the next slide. Here's what SSJC proposed to the Montgomery, the next one after that. Sorry, thank you. Here's what we proposed to the Montgomery County Council last spring. Fund mental health crisis teams 24/7, invest in a CAHOOTS model attuned to the demographics of Montgomery County, hire many more bilingual licensed mental health staff who are steeped in cultural humility and knowledge, hire a core of bilingual peer support specialists and outreach workers. Continue with that slide, the next one. Establish a dedicated mental health crisis hotline staffed by bilingual mental health providers. Invest in a multilingual, multicultural public education program. Develop a crisis response advisory group comprised of impacted individuals. And crisis teams should be thoroughly assessed and all data made available to the public. Thank you. Please stop sharing. In the past few months, Montgomery County HHS has received 2 grants from SAMHSA that will support the expansion of mental health services and provide substantial funding for mobile mental health teams. And Maryland is one of 20 states to receive Medicaid funding that will support mobile mental health teams as well statewide. I'd like to talk to you now about CAHOOTS, the model program that inspired our advocacy and vision for change, which started in Eugene, Oregon over 30 years ago as a grassroots volunteer program that emulated the free clinics and street health outreach of the 60s and 70s. Whitebird Clinic, a nonprofit multi-service agency, eventually housed and managed CAHOOTS, the acronym for Crisis Assistance Helping Out on the Streets. Today, CAHOOTS works with the counties to support prevention and intervention services for people experiencing mental illness, complications of substance abuse, and/or to assist unhoused individuals. In the past decade, they expanded their services to be available 24/7. CAHOOTS prioritizes verbal de-escalation and the capacity of its staff members to make quick and authentic connections with the person in crisis. The emphasis of their work is on support and stabilization at the site of the encounter. They value providing the least intervention necessary. In 2019, of 105,000 calls for service, 18,000 were responded to by CAHOOTS in Eugene. Of these, 311 resulted in a call for patrol coverage. A program that cost $2 million saved Eugene and neighboring Springfield, Oregon, roughly $14.8 million in 2018 through diversions from the ER and jail, and by providing services that do not require the more costly expertise of fire and rescue or police. Crisis calls diverted by dispatch to CAHOOTS resulted in the compassionate assistance of a team in a van comprised of a mental health worker and an EMT wearing CAHOOTS t-shirts. It's friendly, low-key, and attuned to the person in crisis. Eugene and Springfield are saving millions of dollars in county funds and can use the time of police and fire and rescue for more serious health and safety needs. Police are called when it is clear the scene is violent or that the CAHOOTS team may need backup. Whitebird Clinic reports very few incidents of violence against their staff and no serious incidents in the 30+ years of its existence. CAHOOTS is staffed by many people with lived experience. When hiring, they prioritize people who can make an immediate empathic connection, whatever their educational background. All staff receive 500 hours of training in the field and 30 hours of classroom training before they go out in the community. Their goal is to resolve issues on site. After they have exhausted all the attempts to help someone on site, they may transport them to a crisis center, ER, sobering center, or shelter. I think many of us here today can imagine what it would be like to have your friend, family member, or client go voluntarily to the ER or shelter with 2 friendly and compassionate people, rather than be taken in handcuffs to the ER by armed police officers with at best 40 hours of training. The CAHOOTS approach to prevention and intervention, as Marilyn said, is being replicated in several municipalities around the country. SSJC convinced our county government in Montgomery County to consider that a CAHOOTS approach could improve crisis response by reducing police involvement and increasing peer support. This summer, CAHOOTS began training and consultation with Montgomery County government and presented their program at a community forum. While there is not a seamless connection between the culture of CAHOOTS and the large bureaucracy of Montgomery County, we believe there is still much to learn from CAHOOTS that can be applied to large jurisdictions with well-established mental health systems. First and foremost, we can rely on peers and licensed mental health professionals to handle all nonviolent crisis calls and even many calls that may be in a gray area. When a non-threatening, attuned team arrives to help someone who is agitated or aggressive, it is far more likely that the crisis team can de-escalate without police. Second, we must prioritize hiring people with lived experience to be able to connect easily with anyone experiencing a mental health crisis. And finally, we can counter the stigma of mental illness as dangerous by shifting how we care for those in need. Now I would like to read to you an account by the white mother of a Black man I will call Charles, a recent college graduate and college football player who had an encounter at home in Silver Spring, Maryland with police. And we are grateful to this woman who I will call Roberta for sharing her story today. She is a member of Silver Spring Justice Coalition. We met her in 2018 at a community forum on alternatives to mental health crisis response. Here is her account, and I quote, "An acquaintance called 911 because they thought my son might be suicidal. He was very upset about something racist that happened at work, but he was okay and I went to bed. We didn't know the person had called 911. The police came around 10 o'clock. I heard them knock at the door, but didn't realize it was police. Charles stepped outside because we have 2 dogs, pit bulls, and he didn't want them to jump on the police. And he didn't want the police coming in to mistake them for their actions for aggression. So he stepped outside. It was one officer to start. Then another one showed up, and the second was very aggressive. From the body cam video that I saw, he asked Charles what happened. Charles said he was fine. The officer got in the car and called the person who called 911 and pushed him to say what Charles had said to him. Charles has said he was just over being treated badly and just didn't want to exist anymore. The person reiterated he just wanted to make sure Charles was okay. The police officer got out of the car and said, I heard his side of the story, what's yours? Which just seems so aggressive, like why approach someone potentially vulnerable like that? Then that officer turned and started going towards the house, and Charles rushed past him and stood at the door with his arms out and said, I know my rights, you just can't go into my house. At that point, they jumped on him, pushed him onto the ground, handcuffed him, and laid on him. Charles started yelling for help, and that's when I came out. I was trying to get the police off of him. They asked me if I knew what happened at work, and I did. Then 2 more police showed up. They pulled me away and then put him into a car. I asked where they were taking him, and they said they had to figure that out and would call back. I asked why he had to go anywhere, and they said it was too late for him to stay home, that he had to go. Charles refused to get into the car until he heard them tell me where they were taking him. My entire street was outside watching at this point. We got to Laurel Hospital about 11, and they wouldn't release him until the next morning. No reason really, except there wasn't anyone to evaluate him, and he wasn't in crisis, so he was last on the list. I got a bill for more than $1,000 and had to pay $175 at the ER, or they wouldn't release him. The whole thing was nuts. When I met with Chief Jones, he showed me a little bit, but not enough of the body cam for me to see how it escalated. He said that it was a good thing they didn't charge him criminally, but I have no idea what they would charge him with. The chief said disturbing the peace since he was yelling when they pushed him on the ground. I had a really hard time getting anyone to hear. I filed MPIA requests for the police report, the use of force report, the body cam video. I only got to see the video when I pushed for a meeting with Chief Jones. Charles spent the next 4 months in therapy and couldn't get himself out of bed to work for many months. He was traumatized by the whole thing. Finally, I'll just read an excerpt from the letter that Roberta sent to the police chief after meeting with him. Here's Roberta again. I think that while one of them had intensive crisis intervention training, the police approach did not fit mental health suicide prevention best practices by SAMHSA and APA and NAMI. Yesterday, I heard only law enforcement terms. Take him into custody. I heard his side of the story. What's yours? He admitted it. Charge him criminally. I'll admit I thought the meeting was fine and I felt like I was heard until the end when Chief Jones said, he's lucky we didn't charge him criminally. That's jarring when I know that my son, suffering from severe anxiety and depression, would not be alive today had that happened. This was a cry for help, not punishment. Yet what I'm now processing is that it was all punishment, and I'm disappointed. I recognize that you can't respond with mental health professionals to every call. However, this response wasn't appropriate. Approaching things as an interrogation, getting him to admit that he said he wanted to harm himself shouldn't matter. You received a call and someone was concerned. Why not approach it asking, how's he doing? How is he feeling? Get a sense of who he is at that moment in time. Interrogation isn't an approach. We all see the news every day. Police have it tough, but there are also some people who target brown people. Whether or not your officers were biased doesn't matter. My son has seen enough on the nightly news to know police have shot dogs in people's homes and have hurt people of color. That's enough for him to protect the house and himself. He did have rights. You can't protect people who are going through mental health challenges with punishments. Charging people who are potentially suicidal actually makes the community less safe. It shows me that even with training, you don't understand mental health. Therefore, how can you respond to someone going through it? The message again is don't tell anyone when you feel hopeless or sad, because if the police are called, you will be punished. Our thanks to Roberta for sharing her story. And I'd just like to end with considering what would happen if a mobile crisis team based on the CAHOOTS model had replied. We recently learned from Roberta that Charles has moved far away. Let's consider. So an acquaintance is concerned and calls 911. A mobile crisis team is sent because the caller clearly identifies a mental health concern, and the dispatcher is trained to recognize this. The mobile crisis team knocks on the door. Nothing about them is intimidating other than they are strangers. They ask Charles, are you okay? If he is safe, because a friend called to ask them to check on him. Charles goes outside and says he's okay, just sad and angry about things at work, feeling depressed, but he's not about to hurt himself. He doesn't want to go to the hospital. Roberta comes to the door and listens and says she knows her son. He has anxiety and depression, and she knows he's struggling, but he doesn't need to go to the hospital. The mental health team chats with Charles for another 10 minutes to get a better sense of how he is feeling and if he wants to talk about what's been going on. When they leave some resources for a therapist and a hotline. Charles and his mother feel listened to and respected, and Charles feels that people care and there is a good resource in the community if he ever needs it. And I'll pass back to Marilyn for her scenario.
Thanks, Naomi. This scenario is based on actual events, but the names and some of the information are disguised. Sam was a 45-year-old Black man who had just rear-ended a car on a suburban road and was acting erratically. The other motorist in the damaged car called the police and remained in his car. A veteran police officer arrived on the scene by himself. Sam, who had exited his car, picked up a pole he found on the road and hit the officer with the pole. The officer attempted to use his taser to disable Sam, but it failed when he tried to use it. When Sam attempted to strike the officer again, the officer shot him multiple times and Sam died at the scene. Sam's family later described him as having devolved into a serious depression related to recent difficulties at work and medical issues, and may have been using medications that made him anxious or had been drinking, or both. If a 24/7 CAHOOTS style mobile crisis team were in place, the officer could have instructed the other man to stay in his car and call the mobile crisis team, or the officer could have gotten back into his car and called them. The team could have arrived to assess Sam's dangerousness and their ability to de-escalate the situation, inquiring why Sam drove into the other car and why he was so agitated. They could have encouraged him to put down the pole and reassure him he was not about to be arrested. It could be that although he was threatening the officer with a stick, that it's not likely, hopefully, that he would have threatened unarmed and non-uniformed crisis team members or trained responders. However, it is a possibility that had they arrived on the scene, that there would have been a completely different outcome. The team would have also contacted the family, who realized the seriousness of Sam's condition, but had not called for help themselves. The family could have disclosed to the team that nature and origin of Sam's situation and encouraged him to go to a crisis bed or a stabilization center, and then develop an ongoing treatment plan to deal with the family involved. Another point of this scenario is that with greater community knowledge of non-police resources, families themselves could learn to call for the crisis team or for appropriate help themselves. Thank you all for listening.
Thank you. Thank you so much. Such important conversation, Naomi and Marilyn. Thank you. I just want to open the conversation and extend it to questions. We now like to open the workshop for questions. If you have any questions, please post them on your social wall for this session to the right-hand side of your screen. When posted on the social wall, please be aware that there is a 20 to 30 second delay between the presentation and the stream on Conference Tracker. So please be patient as we review your questions and comments. If we do not have time to answer your questions today, please send your questions and the name of the session you attended to connection@namimaryland.org. And so we do have a couple of questions and maybe a comment for the presenters. One says, "Hi, Naomi. So it seems like SSJC is focusing on the crisis line. However, the 988 line will be through Every Mind, which is a separate system and run by volunteers and not clinicians. NAMI MC Advocacy is looking to support Every Mind 988 system, so we may be crossing each other in terms of our advocacy. It will also impact the communication and education. Which number is better for families and individuals on which line to call?"
Thank you for this question. And I am going to say that I don't know exactly. And I think what we're promoting is something just sort of generically, that people who are in crisis get to the right services. We are actually in lots of conversation with Dr. Rolando Santiago, who's the head of behavioral health in Montgomery County, and also will soon be meeting with the police chief and the head of Health and Human Services there, because it isn't clear to us what the plan is. We know there will be changes to dispatch. And from what the last we heard from them at the community forum this past summer, it sounds like there's going to be a coordinated central call center from which things will get dispatched. I knew also in our conversation with Delegate Charkoudian this past week, she will be working on legislation about moving from 911 to 988. So I also want to extend a hand to everyone at NAMI and Every Mind. We would love to work together with you. We don't certainly really have a favorite way of doing this. We just want to make sure the people who need the help have an easy way to get to it, and that it's a number that they can access easily. Marilyn, do you want to add anything?
Yeah, so yesterday in the plenary session, one of the persons from the Mental Hygiene Administration talked about the evolution to 988. And even she said that it was not a clear process or how the funding was going to work. It's in the works on a national level, and it's going to take time for that to be implemented and funded, and for people to learn to use it. But it is integrated with the suicide prevention hotline services that already exist. I wanted to just mention that I also am a former employee of Every Mind, so I'm all for working with Every Mind, and very thankful that they've gotten the role of integrating the 988.
Yes, thank you. And then we have a comment that I'm pretty sure we can agree with is, don't handcuff, help them get the right treatment. And so thank you for the comment. Any other questions? All right, so I don't see any other questions. However, Naomi, Marilyn, do you have any comments that you want to give us before we depart?
Well, I would like to emphasize what Naomi said, which is we are really eager to join with NAMI and with the Mental Health Association on the state level, and with Every Mind, and with providers on helping in any way we can to implement what they see as important.
Mm-hmm. Yes, and I'll add to that we're very aware that not every county has the kind of funding that Montgomery County has, or sort of a pretty progressive council and leadership and so on. And, I would really invite you to look into not only what CAHOOTS is doing, but models like Mental Health First in Oakland and Sacramento, because, people getting together, volunteers like at Every Mind, can actually do a lot to provide safety and support to people in the community. If you know that your county isn't about to be able to, establish something soon, there are things that we can do as concerned citizens and family members and so on. And thank you all for listening today.
Thank you. Thank you. So that is all the time that we have for now. And thank you all so much for joining us today. When this workshop session closes, you will be prompted to fill out a brief survey. If you would like to receive CEUs for this workshop, you must complete this survey in order to qualify. The next workshop session will begin at 11:20 a.m. Be sure to check out our NAMI land and other amazing virtual resources in our virtual exhibitor hall. Don't forget to participate in our resource scavenger hunt. If you can find all the resources listed and submit your answers by the end of the conference, you will be entered in a raffle to win a DSW messenger bag. Thank you again for joining us, and we hope you enjoyed the rest of the conference. Take care.